Thank you for joining today's Nile webinar. My name is Lisa, and I'm the Education Manager for Immunize Nevada, and I will be today's moderator. Before we get started, I'd like to review a couple housekeeping items. First, locate the chat box in the bottom left corner of your screen. If you have any questions, type them in the chat box throughout the presentation, and we will address them at the end. Secondly, if you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey in the post-webinar email. The email will be sent out by the end of today, and all CUs will be emailed out within the next week. A little disclaimer. Immunize Nevada's Nile webinars are made possible by the generosity of speakers who donate their time and expertise to the benefit of the coalition. The expectation and goal is for community partners to gain knowledge on immunization-related topics through a non-branded, unbiased presentation. I'd now like to turn it over to our speaker, Mitch Rothholz, who is the Chief Strategy Officer for the American Pharmacists Association. He is a 1984 graduate of the University of Florida College of Pharmacy and earned a master's in business administration, healthcare management from Regis University in 2005. He has worked on projects involving collaboration between pharmacists, physicians, and other healthcare professionals, leading to improved patient care outcomes, and has spent the last 23 years working with other immunization stakeholders on the creation and implementation of immunization neighborhoods. And with that, thanks for joining us today, Mitch, and I'll have you take it away.
Thank you, Lisa, and thank you, everybody, for spending your time this morning to hear this presentation and to have a good discussion, hopefully, at the end. So if you have questions that come up as I'm doing the presentation, please feel free to write them down, put them in the chat, and we will get to them after I finish through the slide presentation. So let's begin. So as Lisa said, I'm going to touch on the pharmacist's role within the immunization neighborhood, and I'll explain more about immunization in a couple of slides. But that's really an approach that we came up with as a way of bringing together everyone in the immunization arena, an area that everybody's working in to improve public health. As formality, the disclaimer, just to disclose that my wife works for Merck and that I'm an employee of the American Pharmacists Association. So as we talked about the immunization neighborhood, to kind of set the stage for the presentation that I'm going to be giving, I'm going to be focusing my comments around the adult population, but you could really take the concept of the immunization neighborhood and put into any targeted group or area that you're trying to focus on, whether it's immunizations or other disease management activities. The concept of the immunization neighborhood was coined by APHA in 2012 and has been embraced by many in the public health community. And what it stands for is what we call the 3 C's: collaboration, coordination, and communication among immunization stakeholders who are dedicated to meeting the immunization needs of the patient and protecting their communities from vaccine-preventable diseases. And as you can see in the graphic that's on the screen, it's very patient-centered. What we're trying to do in this approach is serve the needs of the patient, serve the needs of the community from a public health perspective, and everybody collaborating and working together from the sharing and exchanging of data, from the implementation of the NVAC Adult Immunization Standards, which talk about assessing, administering, and referring patients to receive appropriate vaccines. When you look at from our country and how well we're doing from the Healthy People 2020 goals, you can see there are a number of vaccines that are on this chart here where we still have a ways to go. And so in reality, it's everybody working together to improve these rates of immunizations. And I want to go through some things that are out there in the arena to just kind of show you where there's the challenge, but where there's also opportunity for collaboration. So for example, in patients with diabetes, as you're aware, the ACIP recommends that these patients do get their hepatitis B vaccine series. And this graphic shows you how well or how not well we're doing in reaching that population. One of the interesting things, and we were excited as a profession when this recommendation came out about hepatitis B vaccination for patients with diabetes, but one of the barriers that's keeping pharmacy from engaging to the fullest extent is that Medicare Part B, which is where it's covered for the Medicare population, doesn't recognize pharmacists as one of the providers who can administer the hepatitis B vaccine to patients with diabetes. Now, we're trying to get that changed and worked on, but it's a legislative fix versus a policy determination from CMS. So we're working on trying to get that addressed. Again, keeping in mind what we're trying to do is address needs of patients and targeted patient populations. Another area for targeting for pharmacists and all of us in the immunization neighborhood is looking at influenza. And I'll tell you how this season's going because I think everybody on this call is living it every day. But where the value of getting your influenza vaccine is coming into play in a way of arguing or articulating the importance of getting vaccinated is when you look at some of the studies, and there was a recent one in January, a Canadian study that was released that showed that individuals who get influenza have increased risk for heart attacks or other cardiovascular events. And so while it wasn't the primary reason for vaccinating, it's a ancillary reason that we could use to articulate to the public about the importance of protecting themselves from getting influenza. The pregnant population is another area where there's a need to increase access and increase education regarding the importance of immunizations. And so you see in the slide it talks about some of the increased risks of pregnant individuals if they do contract influenza and the importance of each pregnancy of each season of them getting their influenza vaccination. And so again, another opportunity for us, A, to deliver messaging, and B, where appropriate, to administer the vaccine. Increasing access is one area and one approach for us to look at as a neighborhood of how do we get people vaccinated with the vaccines that they need. We put together this slide as a consideration to try to get a dialogue going, and I've really bought into this as a potential activity for professions and communities that are trying to do something to help their community in the recent opioid epidemic that's going on. Well, we know with zoster, for example, one of the biggest problems with individuals who do contract shingles is the post-herpetic neuralgia, and we all know that that's a very painful condition. Well, one of the things for treating those symptoms is the use of pain medication, and opioids have a role in there as well. So what would be the impact if we were able to get individuals who are at risk of developing shingles, get them protected from contracting zoster and shingles, and get them vaccinated? So that could be a reason for us to go reach out to the public and educate them and to communities to tie into their activities that they're doing within their communities and public health about the opioid epidemic, but again, tying immunizations into those messaging. One of the things that we've been observing in the zoster vaccination area is something that we call an abandonment factor. And a study that was published just gives you an example of one of the problems with increasing zoster vaccination rates in communities, where the overall abandonment rate in this study showed it was almost 40%. That's basically you get everything worked up, you talk to the patient, you get them convinced, and we know about vaccine hesitancy and the amount of work that has to be done to get a patient to say, yes, I want to get vaccinated, only to get to the point where the out-of-pocket cost that is being told to the patient that they have to pay becomes a barrier where they say, oh, well, no, I don't want it. And so they've been looking at that abandonment rate, and in this case, again, it was at 40%, but that comes into highlighting the importance of us looking at policies, looking at payer policies, and what a patient has to pay out of pocket to get some of the vaccines. And I think collectively as a neighborhood, we need to look at and work together to try to resolve those barriers. So this current influenza season has brought a lot of attention to the importance of getting influenza vaccination. Again, as the recent study report that came out yesterday in terms of the efficacy of the current vaccine, the key message that we all need to deliver consistently, and this is one of the important concepts within the immunization neighborhood, is consistency in the delivery of the messaging from all the providers that patients and the public come in contact with. So if we're all delivering the same consistent message, that hopefully it will reduce the confusion that is out there in the community and the market. And so in the case of the influenza vaccine, we know the message is you still should get vaccinated. It does have a value. If you do contract influenza, it reduces your symptoms and your time of being sick. So it's important to get vaccinated. That's kind of the across the word message that's in place. And one of the things that's on this slide that I'll touch on, and I'll touch on at the end too, is for all providers of vaccination is to pay attention to their technique in administering, whether it's influenza vaccine or other vaccines, because we're seeing increased reports of shoulder injuries related to vaccine administration, that we want to make sure that providers, whether it be pharmacists, nurses, physicians, public health officials, anybody who's administering vaccine, do an extra check of making sure your landmark is placing the injection at the right location within the muscle. So we'll come back at the end and reiterate and show you that as well. But again, that's important for all providers, not just pharmacists, all providers of immunizations to be more conscious of that factor. In terms of vaccine supply, there's sufficient supply. We haven't heard of any shortages at this point in the season. Where we have heard shortages is more with the antiviral, the Tamiflu, etc. And there's solutions that have been put forth on CDC's website on how pharmacists and other providers can deal with those. But in terms of vaccine supply, we've got the supply. We need to just get them in the arms of patients who would benefit from them. Now, when we work with the adult population, it's a little different than the pediatric population because adult patients access medical care at multiple points. But the key is it doesn't matter where they get their vaccine, is if we're all working together, we're coordinating, we're communicating, and we have the same messaging and the same goals in place. We want to take advantage and don't have any missed opportunities. We want to assess the patient's needs. Now, in the adult population, when you're dealing with Medicare, we have a unique situation where we have some vaccines that are covered on the Medicare Part B, like boy, and the two main ones there are flu and pneumococcal vaccine. And then you've got the other vaccines which are covered under Part D like dog of Medicare. And it becomes a challenge for providers to know which way they bill, how they have, what's the process for billing, and so that's something that, as a neighborhood, we can coordinate together and understand how those work and where appropriate referral would be necessary to meet the needs of patients. We also have different payment rates from payers. Again, depending upon who it is that's providing the vaccine, there are different types of payers, and there's recognition of in-network or out-of-network, which impacts the availability, the accessibility for patients to getting vaccinated in their communities. So, for example, there are some health plans where pharmacists are not recognized to provide some adult vaccines, or even public health departments aren't recognized as in-network providers. Those become challenges. Some specialists are not recognized as in-network providers. And so those cause challenges for the patient and for providers who want to refer patients to those providers that we are trying to work on as a system to overcome those barriers. There is no federal vaccine for adults program, although there's been some discussions in Washington about that as a potential solution. Right now, as a nation, we don't have that. There are some states that are looking at something like that. And then there is, again, the whole registry documentation of vaccination across the whole provider community for adult vaccines. We do a pretty good job as a country for the pediatric vaccines, somewhat for the adolescent population, but again, I think for the adult population, it's mixed and across the board. One of the things that is also a challenge, we'll talk about that in a little while when we're talking about implementing the NVAC Adult Immunization Standards that talk about assessing the adult's vaccination history, is that not all providers are reporting to the registry. So if you go to the registry to try to use that information to assess a patient's immunization status, the record's not complete. And so does that deter providers who are trying to use the registry to assess a patient's vaccination history? Does that deter them from going back there if the information is not complete? So it's an issue from a policy perspective that we are trying to work on as the immunization neighborhood and those who are actively working in that area. An opportunity where pharmacists can collaborate with medicine is around the new MACRA and MIPS quality measures. Again, while the medical practice doesn't need to do it all themselves, if they collaborate with others in their community, as long as the patient gets vaccinated and they get it reported back into their records, they can still get credit for those for a quality measure. So it's, again, working as a team together to meet those quality standards. So when we talk about the adult immunization standards, when NVAC updated the standards, and I happened to participate in that work group, it was a paradigm shift, because a major deliberative decision was made that basically the adult status applies to all providers of care for adults. Whether you vaccinate or not, there are some things related to immunizations that you need to do, which includes assessing that patient's immunization status, which includes educating them and counseling them about the recommended vaccines that they need and making a recommendation of the needed vaccine. And if you vaccinate, to either vaccinate them at that same visit or schedule it when you will do it, or send them to a provider who will vaccinate that patient. Again, it's to make sure that the patient gets vaccinated in a timely manner when they're there, when they're ready, and you've got the vaccine available. And then, of course, documenting the receipt of the vaccine that you've given to the patient. And I'll talk about documentation in a little while. So this one study back in 2012, and I'd be curious to see if we've changed any overall, but when patients were asked, are any of the following vaccines recommended for you as an adult, you could see where the patient's knowledge is in some. They're better with some vaccines versus others. But the other thing that comes out of this is, are the providers making the recommendation to the patient? And how strong is that recommendation to the patient about the vaccine that they need? And so we've created a self-assessment tool. And this could be used by pharmacists or nursing or medical practices, anybody who's doing immunizations, to kind of do a self-assessment of your own practice to see how strong your recommendation for an immunization is. And it's based upon some of the key factors that CDC has put out in terms of guidance and best practices. And it's got a twofold, this form. One is that by reading it, you'll be educated about some strategies you might consider using in your practice. But then it shows you where you are. So whether you're completely there, whether you're partially doing it, whether you're consistently doing it. And the goal of the tool is to get practices and practitioners to 75% of the time being in consistently doing that activity. These activities have been shown to be effective in getting patients to take your recommendation and to be consistent in how you do it. And so there's a link on here where you can see the self-assessment, and you can actually fill it out online. And we are trying to collect some of the benchmarks for it as well. So let's spend a few minutes looking at immunizations from the perspective of pharmacists and how they are working in the immunization neighborhood, and how you in your situations could collaborate with pharmacists if you're not already doing so. So from the pharmacy perspective, we actually have three populations that we can reach from the pharmacy practice. The general public, they come into pharmacies to buy all kinds of different things, or just shop, or just looking around. And then you've got the customers who actually are buying things in that pharmacy, who are a little, have a little more connection with that pharmacy. And then those patients who receive prescriptions are another area where we can deliver messaging and targeting of patients based upon their medical conditions. When you look at what pharmacists are administering in their practices, and this I think is a conservative number coming out of CDC. This is for the 14-15 season, but I think it gives you just a snapshot. Really, when you're looking at the majority of the immunization activities that are happening in pharmacy today are in the adult population. I think that number is probably higher today than what that study was showing back then. This is based off of the behaviorist surveys and some of the other surveys that CDC is doing, an internet survey. So you can see here it says 25% in pharmacy. Again, I think it's higher. We're also seeing pharmacies that are participating across the lifespan based upon the needs of that community. Pharmacists are being asked to participate more in adolescent immunizations because we know that is an area of need for a lot of communities. How do we reach that adolescent population with messaging and the delivery of immunizations? And so what we're trying to do is we're trying to be that partner on the immunization neighborhood team that can help get the messaging out to communities and help deliver needed vaccines as an access point for patients who need to have that access, to need to get that vaccination. Pharmacists have been trained for over 22 years. We've had a certificate training program, a 20-hour training program that really lays out across the lifespan, because one of the things we did early on in developing education for pharmacists and immunizations is we wanted to make sure they were knowledgeable and able to respond to questions regarding vaccines across the lifespan, so that they're not actually administering those vaccines. They can at least talk about it with their patients and their community. They can help patients understand the immunization schedules and so on, be an extension and a resource for the public health departments in those communities. In 1996, our House of Delegates actually passed a policy statement that recognized pharmacists' role as either an educator, a facilitator, and we're authorized an administrator of vaccines. And a lot of our guidances that we put together are based upon the guidances that have been developed by CDC and other health professions that we wanted to make sure that we either meet or exceed those guidances in place. And so we talked about a training program, and I'll go a little more into the training program to show you what that entails. But just to kind of show you the growth over the past 20-plus years, you can see here we now have all 52 states and Puerto Rico and D.C. where pharmacists have the authority to administer flu vaccinations, and pneumococcal and a couple others that all the states allow. But the challenge we have in pharmacy is when you see one state, you've seen one state. And so where in other professions, you pretty much can go to any state, it's going to be the same type of authority and scope of practice. In pharmacy, it's all dictated at the state level. And so it makes it a little more challenging for us to give a blanket statement of go to pharmacy to get this, because that state may differ. In terms of training, we now have trained more than 320,000 pharmacists to administer vaccinations across the lifespan. We've also engaged our student pharmacists early in their careers, and we created, and this actually is this program is celebrating its 20th anniversary, but it's a competition among our schools and colleges of pharmacy to again engage student pharmacists in understanding the value of immunizations, going out in their communities and collaborating with partners, again, for educating the public and for providing access to immunizations, and to carry through this importance into their career. And we've seen this occur as students are graduating and looking for practice positions after graduation, and we're also seeing employers who are looking for pharmacists who are wanting and willing to do immunizations as part of their patient care activities. So the education program is a 20-hour program. We have done third-party evaluations of the program and have shown that it is effective in terms of pharmacists and students who are going through this program are taking the information and carrying it forth into their practice. But we also have set up, as part of our organization's strategic focus, knowing that it's just not educating practitioners. They have to stay up to date on the new recommendations, and I'll share you an example of where it's important for all providers to keep up on those recommendations and new vaccines coming out, but that they're also, when ACIP meets, any changes in recommendations, we're providing a webinar after each one with our liaison representative on ACIP who does that update for our pharmacists, so that they have access to the current recommendations and information, as well as we've got listservs, we got e-communities, and we've got articles and publications that help pharmacists have access to the information that they need to keep up. Now, with anybody, any health profession, as organizations, we can develop and provide the information. It's like the horse. You can lead them to the water, but you can't make them drink. So we provide the information the best we can. We make it available, and we hope that people will take advantage of it. And our numbers are showing that people do access the information to keep up with it. But I can't say that everybody does it. So this slide that I'm just showing here shows you the components of the certificate training program, the 20-hour program. There's 12 hours of self-study modules that get everybody coming into the live program with the same basic foundation coming in. There's 8 hours of live. There's a pre-test and there's a post-test. There's hands-on assessments of intramuscular and subcutaneous injections where they have to show the competence to inject, and they inject each other with normal saline, so they get to not only do the activity on an actual human being, but to also feel what it's like to get a vaccination. And then also, as part of the fulfillment of the whole circle of the education, is CPR and OSHA training is an expectation as well. What our Colleges of Pharmacy accreditation body has recently done, they just updated their standards, and public health and immunizations have now become an integral part of the accreditation standards for our education programs for our colleges and schools of pharmacy. And this slide shows you how it's listed in our accreditation standards and guidances. And you can see where it's integrated as activities and expectations of students who are coming out of our programs are graduating with this information and competency. So when you look at what's going on in technology and immunizations, and there's a lot of people are very supportive of pharmacists doing this, but you still have those who are not. People who are wondering what's the future of injections. And recently in June of 2017, story was out about the work that's being done on the flu vaccine patch. And so where people are concerned about injections or getting injections, technology is going to come out where it's going to be easier to get patients vaccinated. So here it's a patch. So how much knowledge and skill does a practitioner need to do, or is this going to be a patient-driven activity where they buy the patch and they put it on themselves? So that's where technology is going. But so as a profession, flu was the entry for pharmacists getting into the immunization area, but we're not just stopping at influenza, because there's a big, as you saw in the numbers and the statistics, there's a big community need in other vaccine preventable diseases and vaccinations that we, again, the immunization neighborhood has to look at. What is it? Flu provides us an access point to have discussions about other vaccines, and how do we take advantage of those opportunities? When you're working with a patient, what other vaccinations do they need that will help them be protected? And so that's something in all providers, in all of our members and providers' mindset is we need to get them thinking about what else can I offer this patient that's going to give them the needed protection while I have them in front of me. And if we're all consistently doing the same type of approach, then we should see increase in vaccine delivery and protection against vaccine preventable diseases. In one project that we worked on, we looked at how many patients have a primary care provider. And in this one study of looking at in California and Michigan, 43% of the patients that were looked at did not have a identified primary care provider. So people are out there in the communities, but they're not connected. They don't have a connection back into the system. And I'll show you in a little while, but what this provides us is an opportunity to get folks reconnected into the healthcare system. If something's identified, to get a referral to an appropriate provider. So we should look at this as an opportunity of all the folks working as part of that neighborhood of opportunity for referral among the players within that neighborhood. In pharmacy, we have adopted what we call the pharmacist patient care process. Again, trying to get some consistency for when a patient interacts with a pharmacist, what should they expect that type of interaction to be? So just like when you go to a physician's office, there are certain things that occur and happen. Same thing with nursing, certain things that nurses will do when they interact with the patient. The same thing we're trying to do in pharmacy is that expectation. What are some of the things that a patient should expect? We created a special module that's specifically focused on immunization services and how do you integrate those services within that patient care process. And so we're doing educational programs around this, and as we're developing our education programs for other types of patient care activities, we're using the patient care process as the template for developing those education programs. A recent demonstration project that was done out in the Washington State area looked at the impact of immunizations and looked at where pharmacists were using the immunization registries as a way of assessing and targeting patients in need of vaccines. And one of the things that the demonstration project showed that by using the IIS and using the information within that data system, the pharmacies that were participating in this demonstration project on average identified 1.45 additional vaccines as being needed for each patient. So the patient requested an influenza vaccination. The pharmacist went and looked at the IIS to see what other vaccines that patient needed or could need based upon the data that was in there. Of course, you verify that with the patient to confirm did they or did they not get those vaccines. But it's a way of using the IIS. It's one of the purposes for the IIS systems that has been put in place is the forecasting and identifying patients in need. The project also looked at unmet vaccination needs, looked at educating the patients about the vaccination needs, and how do we increase the vaccines administered to those patients who are in need. So when you've got them there, you convince them about the importance of it, go ahead and vaccinate, eliminate some delays in getting vaccinated. And so what the project showed that through this process, they were able to increase the vaccines administered by about 41%. So that's pretty significant of using the available tools, be it that they're not totally all complete, but it's a tool that you could use at this point in time to help identify and target patients in need. Another study that was done in 2017 looking at patients and their likelihood to get vaccinated for influenza in a community pharmacy. Again, not a surprise to a lot of folks, is that we saw an increased rate of immunizations that were done in a flu season, looking at a time frame between 2003 and 13, that when policy changed, we saw an increase in the vaccines that were administered because of the access to community pharmacy in this study. And so again, where we've got policy barriers where pharmacists can or cannot administer a vaccine, if you give them the authority, you increase the access, you increase the discussion in the community, you can increase the rates of immunizations. I talked earlier about referrals and the importance of especially patients who don't have a primary care provider. As part of a project that we did with the American College of Physicians, we worked on some potential tools that providers could use for referral. So when a pharmacist is encountering a patient who is coming in for immunizations, asking them a question about other vaccinations they may need or other healthcare issues. And believe it, a lot of providers aren't aware, but this is something that we in the profession recognize that we weren't doing a good job. When a pharmacist referred a patient to a physician or a clinic, we weren't sending along any kind of documentation with that patient. Or we weren't calling that practice and say, hey, I'm sending Mrs. Jones to you because we've identified this and we'd like you, we're sending her to you for a follow-up. So letting those practices know that the patient is coming from the pharmacy. So we're trying as a profession to work on that, a referral mechanism, so when we send a patient, you know that they're coming from the pharmacist. And of course, again, to reiterate to the patient the importance of having those well checkups and follow-up, and the importance of having that relationship with a medical home, a medical practice as well. And so that was the purpose of putting together these tools, and they're also available for people to utilize. Talked earlier about the importance of documentation, but it's really educating the providers as well as the public about the importance of carrying their immunization record with them, just like a medication card as well. So a medication card and the immunizations, they should be carrying those with them, whether it be a hard copy or electronic. The importance of them getting that and carrying that information, the importance of them talking to their provider and saying, are you going to be reporting this to the immunization registry? Those are messages that we created, this poster that you see on the right-hand side of the slide, and the messaging that we're telling patients about updating their records, carrying the information with them. Interestingly enough is that we are also encouraging our pharmacists, when they do send documentation to a clinic or to a medical practice, is to let them know that they're also going to be reporting that vaccination to the registry, so that there's not duplication of effort or duplication of records in the system. And so that's important from that perspective as well. We did a survey of our pharmacy practice computer systems to really find out from them what information do they have within their systems that the IIS require as being reported or want to be reported. And so we worked with ERA to identify what fields are ones that are recommended or required by the IIS systems, and ask the vendors, does your system collect these and are they reportable? And so we broke it down by percentages of the pharmacy computer vendors that say they collect these information. And the difference on the slide between green and red information is that the green identify fields that were identified as required fields. The red are ones that are identified as required, but the IIS system doesn't have a hard edit where those have to be filled in. And so you can see here the 100%, but the real point I want to bring out here, and something that we're working on with our computer vendors, is in this one that has 50% or more of the computer vendors who are collecting this information. One of the things we found is from the consent forms in regards to the lot number and the manufacturer name and so on, it's being collected in a number of these computer systems, but it's being collected as a scanned piece of data. So it's in the file, but it's not in a format that can be electronically transmitted. And so we're trying to educate our computer vendors the importance of that information being able to be transmitted to the IIS systems. And so we're trying to work on that. The other thing we're trying to work on, and we actually have a pilot project going on with the major computer vendors right now that will hopefully spill over into the immunization area, is that the pharmacy computer systems are in a different standard called the ANSI standard, or NCPDP standard. It's one of the ANSI standard that is the barrier, but it's not the HL7 standard that a lot of medical providers use. And so the computer vendors are now doing a demonstration project looking at the implementation of HL7 to transmit data from the pharmacy system. So again, then makes the IIS system so they don't have to support two standards and make that seamless exchange of information. What's happening today with a lot of the pharmacy computer vendors is they're using a third-party vendor, or they're using their own IT systems, that they have a central system in their corporation to take the data coming out of the pharmacy computer system, converting that into a format that can then connect to the IIS, and then pulling the information back to the pharmacy computer systems. So there's workarounds until we get this all worked out that connect to the IIS. And it's one of the challenges for a lot of our providers is they're having to do special fixes for connecting to the various IIS systems across the country, which becomes a timely mechanism that puts a burden on providers. From a continuing education, we call it continuous learning, as we talked about earlier. What we tell our providers is you're not just taking one education program, you're continuing your learning and keeping up on the recommendations. We've created 2 new products this year called Show You Know. It's a 5-question quiz on some key points related to these 2 examples on influenza and pneumococcal. And what that has provided us with is to identify some gaps in knowledge where we might need to target some additional education and information for our providers. One of the things in influenza that we've identified through this process is that providers need a greater understanding about the strains that cause hospitalization and deaths. They need to know more information about the impact of influenza on myocardial infarction. So the studies, that slide I showed earlier, providers still don't understand the difference between high-dose influenza vaccine and adjuvanted vaccine, the timing of when to do influenza. And I'm sure if we had other health professions do the Show You Know, we'd probably have similar gaps identified. But what's the correct timing according to CDC and the season? And then the one nice part of it is we added a question in there about shoulder injury, and 90+% of the respondents knew what that was. So we feel good. At least they know about it. Now the question is, are they carrying it forth into practice? And then we've released a product recently, along with the American College of Physicians and the American Gerontological Society, on aging and immunity, about the role of vaccines, again to show, provide and educate providers about how aging impacts the response of an individual to vaccinations, and special considerations that need to be taken into account. On pneumococcal, the 2 gaps that were identified is provider understanding about when to give which vaccine in what order, whom they're targeted to, and groups that should not receive pneumococcal vaccination. So just again reinforcing that education and messaging for providers is what we are looking at. In a collaborative practice, a cooperative agreement that we just finished with CDC, where we're looking at pharmacists' role within the neighborhood. A couple of other points were raised that we were working on in the project, but that we need further work and exploration on, is the challenge of onboarding providers onto IIS systems. Some public health departments, because of funding cutbacks, don't have the staff that's needed to onboard providers. The connectivity to registries across the board, whether it be pharmacy or medicine or nursing or clinics or hospitals. We need to look at the connectivity into the registries and the use of the registries, and then providing information to primary care providers. A lot of our pharmacists are providing this information to practices via fax, because there's not that connectivity, seamless connectivity with electronic health records. And so the recommendation has been, don't let that be a barrier for communicating. So use what you have available at this point, which if it's fax, use that until we get that seamless system available for the connectivity to electronic health record. And then we talked about having the complete information within registries, and educating patients about the importance of tracking their own vaccine. We still need to educate the public about the importance of having that documentation. So the last 2 slides that I wanted to bring out to you are 2 things. Remember, I had talked about when I talked about keeping up with new recommendations, new vaccines that come out on the market. Well, as you know, we have a new zoster vaccine that has been approved and released into the marketplace, and we've had some quick movement involvement in getting those out as part of ACIP recommendations and getting it into the market. And so there is still confusion across the board of all providers in terms of the differences between the Zostavax and the Shingrix vaccine. And so we've created a comparison sheet. Doesn't have every bit of information on there, but the key information that providers would need to know the differences between the two vaccines and some of the considerations that providers need to take into consideration. The other thing that we haven't seen things come out this quick, which is nice, that we now have the updated VIS statement sheet for the recombinant zoster vaccine. That is available. It's available on CDC's site, so providers don't have to use the older VIS that didn't talk about the new vaccine. So now we have the one for both shingles vaccines that providers can use. In regards to the shoulder injury, again, there's some resources that you could use with your providers if you manage and work with multiple providers that you can give them. There's an infographic that you can put up in your practices. You can have refresher discussions with your providers, again, making sure that they're using the right landmark. Shoulder injuries related to vaccines is a reportable incident to VAERS, and so just remind your providers that if there's an injury that is identified, that it should be reported to VAERS as well. So my last slide is every patient encounter gives us an opportunity to educate and advance our immunization status, our immunization rates. And so it's working collaboratively together. Look at ways so you can collaborate with pharmacists to increase access to vaccinations, as well as educating your public across the lifespan. So whether pharmacists in your state can administer to pediatric patients, they still can deliver messaging. They still can do referrals. They still can help patients and their caregivers about looking at the schedules. Adolescents, it's an open game for all providers across the spectrum because we know our rates are nowhere where they need to be. And of course, the adult population provides that opportunity for collaboration. So on that note, I will stop here and see if there are questions or anything we can do to help.
All right. Well, thank you so much, Mitch. And like you said, before we say goodbye, we'd like to offer a little bit more time for last-minute questions. So please type those questions into the chat box now. We've received a few so far. While we are waiting for the rest of those questions to be typed in, just a couple of reminders. If you have requested nursing or pharmacy continuing education credits for today's webinar, please make sure you complete the survey in the post-webinar email. The email will be sent out at the end of the day today, and all CEUs will be emailed out within the next week. If you'd like to view or share this webinar, the recording will be available on our website along with information for future webinars. So please visit immunizednevada.org/webinars for those details. Okay, so let's start with the questions we've received so far. So somebody typed in and said, I heard an interview where the interviewee said that we have four major pharmacies that were making the flu vaccine this season, and she said that part of the efficacy of the vaccine depended on how the vaccine was made. I don't remember the difference though, but it sounded like the community doesn't know that there is a difference. What is your opinion on this?
Well, there's several manufacturers who are making the flu vaccine, and depending upon the vaccine that is being produced for the seniors, you've got the high dose vaccine, which is more effective in those patients. So you've got the high dose and the adjuvanted vaccines that can be used in your senior population because it has a better response for those patients. Again, as we talked about earlier, in terms of the waning of immunosenescence in patients as they age, those two vaccines provide better efficacy for those patients. The recent CDC MMWR study that was released yesterday shows the effectiveness across the vaccines, and so the differences in the vaccines also come down to whether you have a trivalent or a quadrivalent in terms of the scope of the scope of the different types of variants that are being addressed by the vaccine. So that's why you've got, the trivalent has 3 targets, and the quadrivalent, of course, has 4. So you've got 2A and 2B in the quadrivalent. The big problem in this year's season has been with the H3N2 component of the vaccine. So again, though, we are seeing, depending upon the patient population, a different type of response. It's not as high as we all would like, but it still is providing a benefit for patients to get vaccinated. Again, as I mentioned earlier, it's reducing the severity if they do contract influenza and the length of time that they would be sick. So I think there's, again, as the message from CDC and others is, there is value to getting vaccinated.
Okay, great. Here's another question. Nevada has a mandate for all vaccines to be documented in WebID registry, but not all pharmacists or providers do. There is no enforcing body or repercussions for those that don't. Do you have any suggestions on how to find those not reporting or how to encourage compliance?
Well, it's a good question, and I think it's education to remind providers that it is required. I mean, we've also done some work in some states where they had similar requirements for all providers, like Nevada, and this came from the public health department that said when they did programs for physicians didn't know that they needed to report either. So I think it's an across the board reminder to providers that they need to report to the registries. Secondly, you can also do an audit, knowing what providers, and if you want, take your major pharmacies, in the state and look in your registry and see if you are getting claims from them. So I think that's another way of targeting who you need to do outreach to. Just like you could do match up who's reporting your registries to your medical practices as well. Okay,
great. Well, I'm not sure if you have any other final closing thoughts. It looks like that's all of our questions for today. Do you have anything you'd like to close with?
No, I just appreciate the opportunity and time to speak with you today, and know that we are available for further collaboration and discussion. We are part of the immunization neighborhood, an active part of that, and are working with the community again to increase our immunization rates and protect our public from vaccine preventable diseases. And it's a team effort, and so we're all in it together.
Yes, it is a team effort. Well, on that note, that concludes today's Nile webinar. Again, thank you, Mitch, and thank you for those who have participated, and have a great day.
Thank you all.